Thank you very much. Good evening, good afternoon. I'm Dwayne Schultes. I'm not a doctor, I'm an MBA. And you know the party's almost over when the economist gets to speak. So I'd like to thank you all for allowing me to be here. Essentially what we've done is build a real-world evidence extraction on 3 years of outcomes data from CAR-T from a U.S. patient-level database. Now this has been sponsored by the Dutch government and the Zorgens Institute, ZIN, the health technology assessor. Amir Makadi isn't here today, but I'm going to show some data from him as well. Dr. Daniel Gasol and I have been working in real-world evidence models since 2008. We did our first work building a comparative analysis in breast cancer stratification. We've done work in renal failure, cardiovascular disease, and we did a lot of work for the Italian government on Sovaldi. Amir had seen our presentation about Sovaldi and thought it would be a good idea for the Dutch government to work with us and try to evaluate what CAR-T looks like from an effectiveness standpoint when they're trying to figure out how much it's worth and what they should pay. And increasingly, these are the big issues. So this is the team. It's an international team. We grabbed data from Vanderbilt University. Dr. Jagasia, I'm sure many of you have collaborated with. He's the chief transplant oncologist at Vanderbilt University. Brian Rothman runs all the IT. A couple other folks. Monique is here from Utrecht University. She's contributed to the paper. She's also presenting tomorrow. I would highly recommend you go see her presentation. And Mary Jose has also contributed some feedback, not on the paper, but certainly in some of the research we did. Quickly from the disclosure side, this was funded by the Dutch government. Everything else, you're supposed to look at that for 15 seconds. We'll cut ahead. So why is Amir Makadi of Zin asked me to present this slide. Why is the Dutch government interested? Well, essentially they get handed a clinical trial study which is often based on extrapolated data, and then they have to come up with a value assessment which they submit to the health ministry. Now the benefit of this is they don't have to do it themselves. It's obviously provided. The downside is it's not their data, and as well you don't get any effectiveness measures, nor certainly any comparative effectiveness measures with other options. So we were interested in extracting a pretty robust set to see what we could get and see what CAR-T actually did for real in real clinical practice with real doctors and real patients. So what we did is we extracted the real-world pathway for 5 years from patients that were either treated with basically allogeneic bone marrow transplant, HCT, or CAR-T. And we had a database access of about 3 million patients. We wanted to assess the actual clinical effectiveness. And we avoided extrapolation. So this is, we can actually go down on a patient-by-patient level and say how they performed when they had a relapse, what it cost. And it captures data not only from the approval period in September of 2017, but we also have patients that are coming in and out of the data from clinical trials. So we actually have 3 years of actual outcomes data from patients that have been in the EHR, they've been in a clinical trial. Sometimes what you see is, Vanderbilt was working on some CAR-T indications, not others. They would send them to National Institutes of Health and the National Cancer Center, and then they come back into the EHR after infusion. And so we actually were able to build a pretty robust data set. So here's the actual treatment pathway. This is highly redacted and simulated basically after diagnosis. About 85% of patients respond first line. In Vanderbilt's case, it's 83%. Those are patients that walk out completely healthy. And then we see second-line treatments come in, some respond, some don't. At that point, you have a choice before CAR-T of a bone marrow transplant, and then unfortunately, probably death if you didn't respond to the bone marrow transplant. So CAR-T fits in this space between bone marrow. Now it's sort of, is it a substitute for bone marrow or not? And this is what we were trying to figure out. So of the 2.8 million, 3 million patients we were able to extract from, we've had 637 over a 10-year period that had been treated. We cut that down to 5 years because we felt like more than 5 years would not account for the introduction of monoclonal antibodies, inotuzumab, blinatumomab, tocilizumab, etc. So from that first line, the 83% who responded, that's the 529. That left us with 108 patients who were non-responders to the first line. From that, we had 62 patients that we had gaps in the data that was not robust, so we excluded them, and that left us with 49 in this Venn diagram down here on the left. So 29 for bone marrow transplants, 14 for CAR T, and 11 with blinatumomab. Now the thing about blinatumomab is it's a bridging therapy, so we left that out of the analysis. So really we did this as a head-to-head comparison between bone marrow transplant and CAR T. So big data, we had 500,000 ICD codes, we had 750,000 payment codes. We linked the ICD codes to the payment codes and then linked that to the Medicare, Medicaid database of the United States government, which allowed us a vanilla cost across all the treatment pathway. We could go all the way down to Band-Aids, to toenail clippers, you name it, we had everything in the data. About 2.5 million drug records, and then we also worked with Medicare Part B and D databases, and we also had consultations, as I've mentioned, with several practitioners. So, one of the problems you run into with ICD codes is how do you determine a relapse? As we often don't know if someone falls out of the data if they died or if the data was just missing, we decided to go for relapse-free survival. Now, ICD codes we found often in the US are used for maintenance therapies. So something that triggers a relapse for a chemo treatment is not a chemo treatment relapse, it's just a maintenance dose. So that was problematic. So we had to figure out a way to do this. So what we found is you have a baseline of activity, about 1 standard deviation of hospital codes in the record. And then we found when we went above 1 standard deviation, that was an indication of a relapse, and then we would dig in and look for second-line treatments, inotuzumab, blinatumomab, the monoclonal antibodies, asparaginase, updoses, etc. And then we were able to have a very, very accurate representation of exactly at the point a patient relapsed. So this is a relatively new methodology with sort of like a visual pathology in some ways. And so this allowed us to go patient by patient, record by record, to determine the exact point of relapse. So, this is probably not going to make a few people happy, but this is what we saw in the data at the extraction. What we see is that the 3-year survival probability is about 46% for CAR T, and again, it's a fairly wide confidence interval, but it is quite a small population, and it does bias to the downside. And then with the bone marrow transplant, we see that we have a survival probability just a little shy of 68% at 3 years. Now, why is that? We were very curious about that, and so we dug in a little deeper. So here's what we found. In actual fact, the blue line represents the treatment before the second line treatment. So this is the response of chemo before they went to the second line. What do you notice? Well, the blue line here goes out to 2,500 days. The blue line here is a little less than 1,000 days. It also is not substantially better than the CAR T treatment. And you can see here, even though these populations are small, because we didn't have a complete data set for everybody, just these patients, the difference was large enough where a log rank test still gives us quite robust statistics. These populations are not the same. The CAR T population has a much higher disease burden. And so what we're seeing in actual clinical practice, doctors doing this for real, they are defaulting to bone marrow transplants except in those cases where they do not have enough time or the patient does not respond. Then and only then are they giving CAR T. This is what we're seeing in actual clinical practice. So, the costs. This is part of the reason why. If you look at bone marrow transplant from a US perspective, the bone marrow units are profit centers. They make money. Plus, there are some issues with the reimbursement for some of these cells. There is a disincentive right now in the US for doctors to prescribe CAR T. At least that's from our research. We understand this is being worked out, but with the cost differential between bone marrow transplant and CAR T, they're not going to pick their own pocket right now, so they are giving the bone marrow transplant first, seeing what happens. So now what happens in Europe is we have a slightly different problem in that this is a tough choice for the HTAs, our clients essentially, the Dutch government. They have to figure out what they want to do. Now they don't have evidence of this being curative in the subpopulation that's non-responsive, in the higher disease burden population, and it's pretty expensive. So at what point does this make sense economically? That's a big question, and we'll get to that a little later, but what we do see also happening then is the evolving clinical practice. Given the fact that you cannot use it, or at least it's not curative, what we're seeing happening is CAR T being used as a bridging therapy to a bone marrow transplant. So this is what we're seeing in the US. This is the longest surviving patient in the data set that we had from Vanderbilt University. You can see you have an infusion of CAR T, and then you have that giving a full remission, allowing for enough space for this to occur, and then you have the patient going out for 4 years. This patient is still alive. So what we're seeing is CAR T effectively being used as a bridging therapy, but, and I'd like to point out, at a cost over $1 million of treatment. So I'm sure if there's any HTAs in the room, they are now gasping and taking a deep breath. But this is the way clinical practice is evolving right now, because the price does not allow, at least according to our research, the price is not allowing enough experimentation for the CAR T to flow up and be used in that less disease burdened population. So what is it going to take for that to happen? Well, we think that you gain efficiency at between 222 and 250,000 a dose, roughly 277, because you can do more CAR Ts than you can do bone marrow transplants. It's less invasive, it's lighter touch, it's more efficient. So if we were to see an efficiency cost of between 222 and 277, we think that works. There was just a study in the Journal of Clinical Oncology that uses a quality assessment and basically mirrors our results. So we're standing on this, and we think that's where this is going to end up. So if we think if someone's going to start producing this for a couple $100,000, then it's certainly in Europe, it'll make sense for this to start drifting up and being used as a substitute. And I believe that's it. Bang on 10 minutes.
Very interesting data, thank you.
I like hard questions, so, but I know you all want to get to the bar, so. Any questions? No? Wow, great. Maria-José? I know you always got questions.
Ibrahim.
Thank you. It's very interesting and very impressive. However, as you mentioned, the number of patients analyzed was really small. So do you have any idea how to increase this number?
Well, this was a first study, obviously, and it was an extraction from one institution with 3 million patients. We think that the ratio of patients is correct, so that's about the exposure we would expect to see. We are currently we'll be launching another study, a comparative analysis in DLBCL between the indications that are currently in the market, so we hope to have more than that. I will say this, according to Dr. Jagasia, this is what they expect to see in clinical practice, that he's supporting it, and everybody who I listed we currently have a paper. The abstract's been approved by Nature Medicine. It's sort of floating around and bouncing around between the various publications, and we're working on revisions. So everyone supports the conclusions on the paper. Okay?
Thank you very much.
Thank you.